Hello, everyone. My name is Stephen Orvac. I'm a current MSN student and a BSNRN who's been working diligently in the area of adolescent psychiatry for the past few years. And today I'm going to discuss using cognitive behavioral therapy for the treatment of depression within our adolescents. I'm going to ask you guys to just go ahead and click to the next slide when I instruct you to, because I couldn't figure out how to make the video and the slide go together at the same time with me speaking. So let's click to the next slide now. Is adolescent depression being treated effectively? The reason I ask this is because continual readmissions on our inpatient unit have been happening since I began working there. So I asked myself, why is this? Why do these kids and their symptoms seem to be getting worse? I see patients come back with increased self-injurious behavior, increased suicidal ideation, lower self-esteem, more depressive symptoms. And, as a nurse, I can't help but ask myself, what are we doing wrong? Is there a better way to do this? And here locally, particularly, this is a big problem. In the state of New Mexico here, our suicide rate is 84.4% higher than the rest of the U.S. Amongst the adolescent population, and that's alarming to say the least. So that being said, let's click to the next slide. I began to ask myself, what about cognitive behavioral therapy, CBT? CBT is great because CBT is a way that these kids can develop with a therapist or advanced practice nurse or doctor coping mechanisms that they can use for life. This isn't taking a pill. This is an actual thought process about something that they can change to stimulate a different emotion, a different action. So I asked myself the following Peacock-style question. In adolescent boys and girls diagnosed with depression between the ages of 12 to 17, how does adding CBT with a family component to treatment compared to using medication alone, such as SSRIs, affect levels of depressive symptoms over a 6-month period? Asking that Peacock-style question, let's click to the next slide. I began my literature review to find evidence. As I learned in this class, RCTs, or randomized controlled trials, are considered level 2 evidence. Inclusion criteria for my search was less than 5 years of age of the publication. Level 2 evidence is applicable to clinical change or a practice change, which is what we're trying to implement here. I use the following databases: CINAHL Complete, Medline, the Cochrane Library, Nursing and Allied Databases, PsycInfo, WorldCat.org, and Academic Search Complete. It's a pretty exhaustive search, to say the least. Keywords used during the search included adolescent depression, CBT, medication, SSRIs, CBT, versus antidepressant medication. Let's click to the next slide. So out of that search, I found 3 RCTs that I found interesting and applicable to this change. However, one of them did not meet the inclusion criteria as it was older than 5 years of age, so that won't be discussed here. The first RCT that I found was entitled Comparative Effectiveness of Medication versus CBT in a Randomized Controlled Trial of Low-Income Minority Women with Depression. And the reason I chose this one was because even though the women in this study weren't adolescents, they weren't far off. They were 18 to 24. And the setting is a similar type setting to here locally. Their setting was poverty level or below. These women were being seen in Title X, state-funded health clinics in Virginia. And again, there were also minorities. Here in New Mexico, we have a large population of Hispanic and Native American. And almost all my patients, too, are poverty or below. So what was interesting about this, let's go to the next slide, is that the key findings within this RCT was that the CBT and medication group had lower scores on the Hamilton Depression Rating Scale at 12 months than the medication-only group, for a p difference of 0.04, showing favorability for CBT in the treatment of depression within this population, which is good. Let's go to the next slide. The effect of CBT versus treatment as usual for anxiety in children with autism spectrum disorders. This was another interesting RCT. Now this focused on children. However, a lot of my adolescents that I get do have autism spectrum disorder, and anxiety and depression seem to be very closely linked together as well. The results from this finding were interesting as well, as the CBT and medication arm of this study showed very much so a favorable result versus the treatment as usual group. That being said, I want to propose the following intervention. Is that based on the findings of the evidence, I would propose adding 2 hours per week of CBT treatment for the depressed adolescent for at least 1 month as a standard of advanced nursing practice care in the treatment of all adolescent depression. The CBT hours should have the same priority as prescribing medication. The two really need to go hand in hand. Next slide. The environment would begin in the inpatient, as patients can be followed up on and monitored daily. However, the outpatient environment is equally important, as follow-up in the continuum of care takes place over the long term. If you guys have any questions, feel free to ask me in the discussion board, and I am out of time here. So here's the references for my studies, and I wish you guys all the best of luck in your journey. Thank you.